Scapula, Dracula, spectacular. Wait a minute, spectacular is not even a word. We're gonna talk about scapulas today, and scapula is one of the two bones that makes up the shoulder girdle. The other bone is the clavicle, and we have different views of the scapula. The first projection we're gonna talk about is the AP projection. The image receptor is 10 by 12 inches lengthwise. We'll have the patient stands with back to Bucky. We'll center the affected scapula, and to do so, we'll find the cord process and center 2 inches inferior. For the right AP scapula, we'll have the patient do a right salute over the right eye and have their hand rolled backwards. At this position, you should see pretty good AP scapula as the lateral border is not superimposed by the rib cage, because the arm is abducted at a 90-degree angle. This allows the scapula to be drawn out laterally. This is a great AP scapula that's properly collimated, and you can see the acromion all the way to the inferior angle of the scapula, and the lateral border is not superimposed by the rib cage. Great bony trabecular detail. I will shoot an AP gridded scapula at 75 kVp in 8 mass. Sometimes patients are unable to abduct their arm at 90 degrees, but have them do it best as possible just because we do need the lateral border not superimposed by the rib cage. For this AP scapula, we can see an apparent fracture through the glenoid cavity, and it is extending inferiorly. Definitely double check your department protocol, whether it's for like ED setting. They may want to include the SC joint. For our lateral scapula, we'll have a 10 by 12 inches lengthwise. We'll have the patient face the Bucky. We'll rotate the patient about 45 to 60 degrees toward the affected side, whether it's a right scapula for RAO or a left scapula for LAO. And the position of the arm will change according to the area of interest. If we're looking at the acromion/cord process, we'll have the patient flex their elbow and rest the back of the hand behind their back. Or if it's for the body of the scapula, we'll have the patient extend their arm upward and have the forearm on top of their head. The central ray should be directed midpoint of the scapula. We do want the medial border and the lateral border to be superimposed. And the method that I personally use is lining the AC joint and the superior angle of the scapula, and then have that perpendicular to the IR. With this method, I have pretty good success rate obtaining the lateral scapula for the very first exposure. If not, I do know whether to rotate a little bit more or rotate a little less. So let me explain my process after seeing the initial image. So for this X-ray RAO position, you can see the lateral border is definitely the thicker border. Just remember that. So the medial border is medial to the lateral border, so the patient needs to be oblique more. If the patient have the medial border lateral to the lateral border, we need an oblique less. I highly recommend straight timing the lateral view of the scapula, just because if the AC is not properly lined up, it could time out relatively fast. This will result in a grainy picture, and it will be non-diagnostic. And the techniques that I would shoot for a gridded lateral scapula for myself would be 75 at 20 to 25 mass. This is a great lateral projection of the scapula. It resembles the letter Y. The upper part of the letter Y is the acromion and the cord process. The lower half is the body of the scapula, and also The medial border and the lateral border is superimposed. We know the anterior process is the coracoid process, and the posterior process of the scapula is the acromion process. So if we happen to see a displacement of the humerus more towards the coracoid process, it will be anterior dislocation. If you see the humerus head displaced towards the acromion process, it will be a posterior dislocation. At Kaiser, they use the outlet view instead. Basically, it's the same positioning of the RAO, the LAO, and the medial border and the lateral border superimposed with the addition of a caudal angle of 10 to 15 degrees. This allows to evaluate the shoulder impingement and the subacromial space. For the AP and lateral projection of the scapula, we'll have the SID at 40 inches, and we will shield the gonads. Don't forget to utilize this amazing communication tool called AIDIT. It stands for Acknowledge, Introduce, Duration, Explanation, and Thank you. The very first step is to greet the patient/family with a smile, ask them how's their day, and double verification that you have the correct patient. The second step, introduce yourself, tell them who you are. The third step, let them know how long the x-ray is going to take. The fourth step is to explain the exam and address any concern and give clear instructions while positioning the patient for that particular view. The last step is to thank the patient/family for being part of their care. Thank you for watching this presentation.